So I'm Andrew Edwards, and I'm going to talk a bit about third trimester surveillance. So the concept of third trimester surveillance is really to detect fetal growth restriction, and just a bit about sort of definitions for a start. So we talk about the small for gestational age fetus, and that's a fetus that can be either clinically small based on examination, or it can be small based on an ultrasound scan. And some of those fetuses will be small fetuses where there's no problem, and for genetics or familial reasons they're meant to be smaller than average. But the other group are the fetuses which are growth restricted for some reason. And the main reasons are listed here. There's fetal abnormality problems such as chromosomal, genetic or infective causes, and then there's placental causes, things such as preeclampsia, lupus, and a chromosomally abnormal placenta. But both of these groups have an increased risk of poor outcome, and so it's important that we're able to detect small fetuses and manage them appropriately. So on most of this talk we're going to concentrate on this latter group, the group of placental insufficiency. So there's simple concepts in this talk that I want to sort of explain. And the first part of it is the concept of the importance of detecting when a fetus is growth restricted or small. So this study by Gardosi's group looked at 92,000 pregnancies over a period of 3 years, I think 2009 to 2011, in the National Health Service in England, and they looked at the risk of stillbirth. And what they showed, and you can see it on the graph here, is that in normally grown fetuses, the risk of stillbirth was 2.4 per 1,000. When there was growth restriction that was detected antenatally, the risk of stillbirth was 9.7 per 1,000. And when there was intrauterine growth restriction that was not detected, the risk of stillbirth was 19.8 per 1,000. So in other words, the risk of a stillbirth is 8 times higher in a non-detected growth restricted fetus compared to a normally grown fetus. So this is a very high risk group, and it's important that we try and detect these pregnancies. But even more importantly, once we do detect that the fetus is growth restricted, the Porto studies shows that we can actually improve the outcome. So they looked at 1,200 growth restricted pregnancies, and they set up an active process of surveillance and timely delivery. They didn't do anything that we can't do. They did routine things, but they just did it in a highly organised manner. And what they were able to show, and this is looking at perinatal mortality rate rather than stillbirth rate, but it's reflecting the same thing, is that they were able to reduce the perinatal mortality rate down to a level very close to the national perinatal mortality rate by actively caring for these pregnancies. So in this growth restricted population that was actively cared for, there was only a 1.3 times increase in the risk of perinatal mortality compared to the national background rate. Now the government knows this, and the government knows this well. The government has a series of performance indicators which it uses to assess the performance of the public obstetric hospitals in Victoria, and this is the latest released information. So they have 10 indicators, so not many, just a handful. But if you look at number three is severe intrauterine growth restriction in a singleton pregnancy undelivered by 40 weeks. And what they do here is they look at the proportion of severely growth restricted babies delivered after 40 weeks as a proportion of all growth restricted babies. The concept is that when an unborn baby is growth restricted, it should be delivered by 40 weeks gestation. So yes, if there's significant growth restriction, the baby should be delivered before 40 weeks to optimise its outcome. So this number should be 0. We should have no babies undelivered at 40 weeks that are severely growth restricted. But in fact, if you look at the table here, you can actually see that in public hospitals, 39% of severely growth restricted babies were delivered after 40 weeks gestation, and in fact it was slightly higher in the private hospitals. So what's this telling us is that we're doing a really bad job at detecting the growth restricted fetus. And when you consider that approximately 50% of pregnancies deliver spontaneously before 40 weeks, it actually suggests that our detection rate may only be about 20%, and that's supported by other research. So the good thing is that we can improve our detection of the growth restricted fetus, and this paper published in the Lancet last year compared 2 ways of detection of the growth restricted fetus during the 3rd trimester. So they looked at 4,500 pregnancies, and in these pregnancies they all underwent normal care, so that if the fetus was thought to be small based on clinical grounds, selective ultrasounds were organised as we would do in Melbourne. But what they also did is that they did 2 routine scans in all of these pregnancies at 28 weeks and 34 weeks gestation, but the results of the scans were blinded. And what they were able to show was that in the selective ultrasound group, using the same style of practice that we use in Melbourne, they only detected 20% of the small for gestational age fetuses. But when they did the universal scanning approach, routine scans at 28 weeks and 34 weeks gestation, they detected nearly 60%. So they had a 3 times increase in the detection of growth restricted fetuses by using routine ultrasound. So I just want to talk a little bit about what we do when we detect that the fetus is growth restricted and what the role of ultrasound is. So it's clear that ultrasound is the primary investigation, and what we do is we assess placental function and what we call fetal well-being, and we use this information to essentially determine the optimal timing of delivery. So to explain this just a little bit, I need to bring up my titanium fetus, which you can see here. So these are the things that we look at during these scans. We look at the amniotic fluid volume, and the reason we do this is that amniotic fluid volume is an indicator of placental function. So just to explain a little bit, as the placenta starts to as the placental function becomes impaired, as the placenta becomes impaired, the first thing it seems to do is lose the ability to transfer food or nutrition across to the fetus, so growth tends to slow. But of course we can only detect growth by doing interval scans, so it can take a while for that to appear. The next thing we see is changes in the amniotic fluid often, and that relates to lower oxygen levels and shunting within the circulation. So we look at the amniotic fluid volume. I'm going to explain these things a bit further. We look at blood flow through the umbilical artery, because when there's placental impairments when placental function is impaired, we see a higher resistance flow pattern in the umbilical artery because the resistance to blood flow through the placenta increases. We look at the middle cerebral artery in the fetus, and you can see here an image of the circle of Willis. So the middle cerebral artery comes off the circle of Willis. When the fetus starts to become hypoxic, the circulation adjusts to preferentially send blood to the fetal brain. So what we actually see in the hypoxic fetus is low resistance flow within the fetal brain. And we also look at this structure called the ductus venosus. It's marked in red up on the diagram on the top left here. The ductus venosus is a little blood vessel vein that directs the oxygenated blood returning from the placenta into the heart. And we see as the fetus starts to become acidemic or acidotic, we start to see changes in the flow pattern in the ductus venosus. And the next thing is that as the fetus gets sicker, as we see changes in movements and breathing movements. So here's my fetus having a little bit of movement. So to represent all of this in a different way, these are sort of the typical changes that happen as placental impairment increases. So the first thing, as I said before, is that we see reduced growth. So the placenta loses the ability to transfer food and nutrition. The next thing is that oxygen transfer decreases, so the fetus starts to become hypoxic, and that's where we see decreased amniotic fluid volume and changes in the middle cerebral artery. As the fetus becomes mildly acidemic, we see changes in the ductus venosus, and as it becomes severely acidemic, we see decreased limb and body movements and decreased breathing movements. And we use this information to try and work out the optimum timing of delivery. Now, the timing of delivery changes somewhat as gestation advances, so our threshold to delivery decreases. But in general terms, in pregnancies before term, so before 37 weeks, we're usually wanting to deliver the fetus roughly in the period of time where there is hypoxia has developed, but acidemia has not developed. So whenever we do a scan and we see a growth-restricted fetus, we do all of these little tests and we can plot in our minds, I guess, where the fetus is. And if the fetus is sort of in this area here, then this is usually when we're considering delivery. So just in conclusion, undetected growth restriction has an 8 times increase in stillbirth risk, but that can be reduced to approximately 1.3 times with appropriate detection and management. In Victorian hospitals, according to the Maternity Health Indicator, 39% of severe IUGR cases are not being detected. But given that a lot of those will have delivered before 40 weeks, it's probably actually 80%. So in other words, we're only detecting about 20% of growth-restricted fetus using our current technique of only doing ultrasounds when we believe that the fetus is clinically small. Universal ultrasound, as in routine scans at 28 and 34 weeks, will detect 3 times more of the fetuses that are small for gestational age. And as I said just then, once we detect that the fetus is small, we go through that ultrasound process to detect the degree of fetal compromise and to guide optimum timing of delivery. Now, there's obviously a question here about whether we are ready in Melbourne 2016 to be performing universal screening for growth restriction. And I suspect the answer is that really we're not. Looking around what's happening, we're finding that sort of a quarter to a half of private obstetricians are performing some form of routine screening, so they're performing ultrasounds in the 3rd trimester, 1 or more. But in the public hospitals, this is certainly not routine. So as we go through this time of change, I guess the most important thing is that we, in our minds, have to set our threshold low for performing an ultrasound when we in any way suspect that the fetus might be small, and possibly increasing the use of ultrasound when there are particular risk factors for growth restriction, such as past history of growth restricted or small babies, hypertension, diabetes, a low PAPA in the 1st trimester screen, and advanced maternal age. So the whole concept here is that we need to detect the small fetus so that we can optimise its outcome and decrease the risk of stillbirth. Thank you for your attention.